oxygenation is way more important than intubation.
Mm-hmm.
But I believe the systematic review about head injuries and intubation in the pre-hospital setting, like you said, I think they recommended it. If you can get it on the first try, patients tend to do better.
Yeah, well, so much treating these brain injured patients in the pre-hospital setting is mitigating those second injuries or like the second like factors like hypoxia, hypercarbia, hypotension. So if we have a patient that's so ill that we're not able to oxygenate them and manage their CO2 without a tube, then obviously doing that is going to be beneficial.
And that's not a prescriptive approach to say like all head injury patients should be intubated, because oxygenation is key. And I know we've spoken about this before, but what are signs that we should intubate? Because I think we're remiss in the education training. It's like, we have this tool now, but you should know when to intubate and when to do an SGA or a BVL. Like, what are telltale signs that we should intubate this patient?
There's been so many changes kind of in the past several years in terms of like recommendations for this stuff, right? With SGAs becoming the first line approach for airway management for most critically ill patients and definitely cardiac arrest patients, right? Like if you have a patient with a medical VSA, an SGA is what they should be getting, especially after like the Airways trials and things like that, right? And even for pediatrics, they've shown that like SGAs have higher first pass success and similar neurological outcomes, similar ROSC rates, similar kind of everything, right? That we care about, and especially what patients care about. However, there's obviously those cases where there's severe airway, like soiling and things like that, where an SGA is not the right option. A trauma patient with a skull fracture, if they've got a bunch of blood in their airway, a patient with a variceal bleed, like esophageal varices bleed, any of those like severely soiled airways, and intubation is definitely going to be preferred, especially since you can then provide deep suctioning and things like that. And obviously, like critically ill patients that require that advanced aggressive airway management will benefit from an ETT compared to an SGA, because we can then like provide sedation and or deep suction and things like that. So, having that actually definitive airway early can be beneficial for a certain cohort of patients. However, I can't just like give you a list of those exact cases. That's why we're going to be, this is a clinician thing. You look at your patient, you think about your transport time, you think about your resources, everything.
Correct me if I'm wrong. In the paper, you discussed how intubating on the scene is different than intubating in the back of the ambulance.
Yeah, absolutely. So I think it was Oren that discusses, like in their airway programs, they discuss like the hierarchy of intubation positions or locations. So like on scene, on the ground is kind of like a mid-range. It's a decent place to intubate because you have space, you have all these things, you have a partner. However, in the back of the ambulance, when it's parked, is actually the best place you can perform intubation, because they're on your stretcher, so you can get more of an alignment. You can position your patient more optimally. You have your wall suction for your solid technique. You have your wall mounted M tank for your oxygenation that you're not going to run out of. And also like your partner's still there because you're parked. And then in the back of the ambulance on the road is the worst place you can try and intubate because, obviously resource limitations, and the movement is going to dramatically complicate your procedure.
So if you find this work valuable, the simplest way is to support the podcast by subscribing and sharing it with someone who'd benefit. And I want to recognize and acknowledge CASPR, which is the Canadian Ambulance Service, Paramedicine, and EMS Research Repository. It's a free, open access platform making paramedicine and EMS research more visible, usable, accessible, and operational across Canada. So a huge credit goes out to Dr. Alan Batt and the team for leading the work and advancing open science in EMS. This podcast is for educational and informational purposes only. It is not medical advice, does not establish a standard of care, and must not be used to diagnose, treat, or manage any medical condition or emergency. The content discussed reflects general principles that may not apply to every situation, system, or patient. Clinical practice varies by region, service, and jurisdiction. Always follow your local medical directives, clinical guidelines, protocols, and the instruction of your medical oversight or base hospital physician. The host guests and producers make no representation, guarantees, or warranties regarding the accuracy, applicability, or completeness of the information shared. The views expressed are those of the individuals and do not necessarily reflect those of their employer, regulatory bodies, or medical oversight authorities. By listening, you acknowledge that the host and guests assume no responsibility or liability for any actions taken or not taken based on the content of this podcast. This material is intended solely as a supplemental educational tools to support ongoing professional development, not a substitute for accredited training, certification, or authorized clinical guidelines.